Now we move on to systemic cold injuries, namely hypothermia. Hypothermia is when our core body temperature drops below normal, and the symptoms and presentation will depend on how low the temperatures get. The textbook definition is a CBT of less than 35 degrees Celsius, but the effects at that temperature are usually pretty mild, so you won't start really worrying until much lower. Important point, typically we see hypothermia in really cold environments, but people can actually become hypothermic in pretty mild temperatures, as low as 6 degrees Celsius, or swimming in a 20 to 24 degree pool for a prolonged period. So a quick review. CBT is 37 degrees Celsius. And when we get cold, our body starts to decrease thermolysis and increase thermogenesis. We decrease thermolysis by vasoconstriction to shunt blood to the core, which is where we get a lot of our frostbite and minor cold injuries. We increase thermogenesis by increasing heart rate, increasing blood flow, and moving blood to our big skeletal muscles. We also try and increase our metabolism. So who gets hypothermia? Well, we're mostly going to be looking at those people who get left in really cold climates. People who get lost or injured outside and can't find their way to safety often end up with some level of hypothermia before they're found. The homeless or those living in poverty are also at risk for being stuck in cold environments. The risk becomes worse when you add in things that cause altered LOC, like drugs, hypoglycemia, seizures, or trauma, as these folks can't find their way back to safety. Traumatic injuries can also affect the mortality of hypothermic patients, as they often can't move enough to increase their CBT. Lastly, the very young and very old often have difficulty with cold temperatures. The elderly, because of their decreased mobility, diminished sensation, and overall lower CBT, while very young patients, because of an increased body surface area to body mass ratio, means they lose heat faster than they can make it. So at 35 degrees, we'll start getting signs of mild hypothermia. That is, we'll start to see shivering, which is triggered by skin cooling, increased metabolism, increased ventilatory rate, cardiac output, and mean arterial pressure. All of these things work to help that shivering increase our CBT. And that can work great for a time. All of these shivering requires energy. And when our body uses up its glucose stores, or when it realizes that these attempts aren't working, then the cold starts to have some more serious effects. At 32 degrees, our physiologic ability to stay warm starts to diminish, and we hit moderate hypothermia. Brain activity begins to slow down, and we start getting confused, lethargic, and making poor decisions. This slowdown in brain activity might have some protective effects, as tissues use less oxygen to try and protect themselves from a noxic injury. We'll also start to see a decrease in circulating blood volume. Blood gets shunted to the core, which causes an increase in renal blood flow, which tricks the kidneys to think they're hypovolemic, so we diurese. Cardiac effects will start at around 32 to 30 degrees, with PVCs and AFib being common, and bradycardia starting as the patient gets colder. Shivering stops at 30 degrees Celsius, which decreases the metabolic demand on the heart. So we'll also see a decreased ventilatory rate, which can also lead to a respiratory acidosis. Below 28 degrees Celsius, we hit severe hypothermia. Patient is definitely altered at this point, with most patients being completely unresponsive, and the heart rate is now likely severely bradycardic, with AFib and runs of VT being common arrhythmias. The heart is also very unstable at this point. Any slight change can put them right back into VF. Things like the acidosis, hypocarbia, and hypoxia are all going to compound on this, so movements by rescuers need to be smooth and slow. Treating the hypothermic patient is tricky. We've got to get the patient warm, but a side effect of rewarming is vasodilation. And as these vessels dilate, that cold peripheral blood can get to the core and cause the CBT to drop even further. This is called afterdrop and can cause as much as a 5 to 6 degree drop in core body temperature, putting people who are in moderate hypothermia back into severe hypothermia. To prevent this, try and warm the patient up at least 1 to 2 degrees Celsius per hour, up until the body can start managing its own thermoregulation again. In terms of how to warm them, step 1 is minimizing heat loss, by getting them into a warm environment, removing wet clothing, and increasing insulation. If the patient has mild hypothermia, they can likely warm themselves up sufficiently, so just monitor them. If patients have lost significant heat or do not have the ability to shiver, Actively heating the patient with hot packs, warm humidified O2, warmed IV fluids, usually at 40 degrees Celsius, and a high ambient temperature can be used. If the patient goes into cardiac arrest, first we have to decide if the patient can even be saved. Look for injuries incompatible with life. Unfortunately, hypothermic patients are often stiff, so rigor mortis and dependent lividity are not accurate indicators to pronounce. CPR is the best treatment, and the goal is to keep them alive until we can get them warm, at least to 30 degrees Celsius. Defibrillation is not likely going to work, so if you see VF or VT at temperatures less than 30, shock once and then wait until they're warm. As for medications, there isn't any great evidence one way or the other, so you'll often see protocols use half doses or double the intervals, or sometimes even withhold the drugs altogether until the patient is warm.